All right, y'all ready? Find my stuff. Okay, tonight really is a continuation of what we were doing last night. And as I told you that your test on Tuesday is just going to be over 2 chapters. So what that means is you need to make sure you know those chapters frontwards and backwards and frontwards. It's just these 2 chapters because airway management is so very important. So that's why I've done it this way. First time I've done it, we'll see how it works. So hopefully you guys will all make 100% on the airway chapter. So tonight we're going to be looking at respiration and artificial ventilation. And ventilation and respiration are different things, so we're going to talk about those differences. We're going to look at what positive pressure ventilation means and why it's important and the pathophysiology of the respiratory system with positive pressure ventilation. We'll look at oxygen therapy, and we've been doing that in the lab, so some of this stuff will start to make sense for you, I hope. And we really are not going to look at assisting with advanced airway devices tonight. We'll look at that towards the end of the semester when we build in a little bit more time. Okay, nothing new here. What's the difference between ventilation and respiration? Somebody tell me what ventilation is. Ventilation is just the movement of air in and out. What's respiration? Gas exchange. What is internal respiration? Where does internal respiration occur? The cellular level. Where does external respiration occur? In the alveoli. Good job. Good job. Okay, so we got a dead guy. Will we be ventilating or will we be respirating? If we're doing CPR. Yeah, we're going to be ventilating. That's all we can do. We can ventilate somebody. They've got to do the respirating part of that. So here we're looking at the lungs here. They're just looking at moving air in and out. That's ventilation, the movement of air in. But a lot of things can interfere with the respiratory side of this, the respiration side, right? What could interfere with ventilation becoming respiration? Puncture. That would really interfere with ventilation, actually. Yeah, if you have any compromise to the lung tissue, the air may not be able to get to the cells for respiration. What else can interfere? What can interfere with ventilation? Yeah, if you had some type of a mechanical obstruction, if you had a blockage in the trachea or something. What else can interfere with ventilation? Hypoxia? Well, you mean, would that interfere with the movement of air in and out of the lungs?
Well, if it occurs, then it does, doesn't it?
Well, hypoxia is a result of poor respiration, really, not necessarily poor ventilation.
Spinal cord injury?
A spinal cord injury could certainly interfere with ventilation. Yeah, if you had a collapsed lung or if you had negative pressure in the chest, that's going to interfere with ventilation. You know, if you're bagging, using your bag valve mask, you're bagging a patient, he's got a big hole in the side of the chest. He's not going to be, you're not going to be able to ventilate him because the air is just going to zoom right out into his chest. So yeah, there are a lot of things that can interfere with ventilation. And some of the stuff we can fix, some of it we can't. We talked about this before. Inhalation is an active process, right? Because what's actively happening? Yeah, but why? I mean, could you just open your mouth and air zoom in? Your muscles contract. Your diaphragm, what does your diaphragm do? What should, okay, when the diaphragm is helping you inhale, does it look like this?
Flat.
Yeah, it's flat. That's right. It's working. When you inhale, what does the chest do? It expands. So as it pulls out, the diaphragm pulls down, it creates negative pressure in the chest, and air will suck in, right? That negative pressure is important, particularly as we move forward. When we start getting into trauma, respiratory problems as a result of trauma, and other medical problems that can interfere with inhalation and interfere with negative pressure. Does everybody understand the negative pressure thing? Imagine if all of a sudden your diaphragm starts dropping down and your chest starts to expand and you can't get air in through your nose and your mouth is blocked. What's going to happen here? You've got a lot of negative pressure in there and it's not able to balance itself. It can't bring air in, right? But as soon as you suck air in, it's going to balance out that negative pressure. Now they have these nice drawings, and I am not a drawing, I like to draw myself, I'm not very good, but I don't understand these little visual things. So maybe if some of you guys have a problem with this, maybe you can use this as a analogy. This is a syringe analogy. You know what a syringe is, one they give you a shot with. You pull back on that plunger, say you have a needle in there, you know when they draw blood from you? You've all had blood drawn, right? They put that needle in your vein, they pull that plunger back, it creates negative pressure in there, and as they pull that, it sucks the blood in from out of your vein. I know that's a terrible analogy, isn't it? But that plunger here creates that negative pressure and draws that blood in. Exhalation is passive. All you got to do is relax your chest muscles, relax your diaphragm. If your mouth's open, your air's going to leave. So that's positive pressure. Now let me ask you this. If this guy had a hole in the side of his chest over here and a bunch of air, say when his diaphragm dropped down, his chest expanded, if the air came in through that hole in the outside of his chest, and his chest fills up with air, what's the pressure going to be like in there? Every time he takes a breath, air sucks in from the outside.
Goes to his neck.
Where does it go? Yeah, it's going to fill all this tissue all around the outside as he tries to breathe, so he really can't create negative pressure to get air in through here. He's bringing air in through the side of his chest. Is that air good for him? All it's going to do is take up space in here so he can't contract. He can't expand his chest in order to take a breath. No air is going to come in. It's being sucked in the side. So that is a way that ventilation is interfered with. And we'll look at this much more in depth a little bit later. Look at that. Okay, there's terminology. We've been here before, right? Have we talked about tidal volume in here? Or did I do this lecture last week for the bridge class? I can't remember. It was here, right? Okay, good. Tidal volume is the amount of air that's moved in and out in one breath. That's your tidal volume. Now, dead airspace, this is an interesting concept. Dead airspace is air that never reaches the alveoli. Like, do I have air in my mouth? Y'all see any? I got air in my mouth, right? Is that air in my mouth used for gas exchange? No, it's part of dead space. The air that occupies the trachea, gas exchange doesn't occur there. So they're figuring that we have about 150 cc's of air that just occupies dead space. So it's not available for gas exchange. So that's important if you're not breathing very much. And we'll talk about that here in a bit too. Alveolar ventilation is the air that's actually reaching the lungs. So say you inhale 500 cc's of air, 500 milliliters of air, and we have 150 cc's that are in dead space. So how much is actually reaching the alveoli? It's a math problem, I know.
You gotta multiply that times that to do it.
Say no. Let's say no.
Which I can't do it in my head, but that's how you.
Okay, I breathed in 500 cc's. How much of that 500 is going to actually reach the alveoli? Yeah, we're going to subtract, excuse me, this dead air space, and we'll have 350. Ta-da. So that is a value that you need to know. Ventilation is going to be inhalation and exhalation. Diffusion. Y'all know what diffusion is, right? Where did you learn that? In biology? I think I learned it in chemistry. In biology? Diffusion, or the movement of gases from a high concentration to a low concentration. For those of you that struggle with that kind of stuff, it's like parity. Whoever invented diffusion wants everything to be equal. So I have this much stuff over here, oxygen, and I only have that much over there. We want to be fair, right? So in diffusion, half of these things will move over here so that we got the same amount over here as we have over there. That's diffusion. Isn't that simple? So it's going to move from an area of high concentration to an area of lower concentration to equalize it. It's like never mind, won't go there. Okay, we talked about external respiration. Yes. Diffusion of oxygen and carbon dioxide between the alveoli and the circulating blood. So when the blood returns to the lungs to pick up oxygen, it's picking up oxygen and it's offloading carbon dioxide. So it's just like that little diagram. On one side we've got a bunch of oxygen, on the other side we've got a bunch of carbon dioxide. And they don't exchange places, but half of each moves over so that it's equal. For instance, what's the percentage of oxygen that we breathe in?
21.
Approximately 21%. Anybody have any thoughts about how much oxygen we exhale? Yeah, we're still exhaling about 16%. We're not using all that oxygen. So when the blood comes back to the lungs, you've still got a fair amount of oxygen in the blood to move, that'll remain there as the carbon dioxide is exchanged with oxygen. So they just want to equalize. That's what they do. Internal respiration is the same. It's going to be at the cellular level. Okay. If there's any of this material that's confusing for any of you, let me know, because I can spend lots of time on it. We've been over it, and if you understand it, I don't want to beat a dead horse. But if you do have a problem with it, let me know. I'm in my office all the time, and I'll talk to you about it. Okay, we're getting to some really important stuff here. Categories of respiratory system failure. So there are different things that can cause respiratory failure, where the respiratory system's not working. We talked about mechanics of breathing disrupted. That's that first group we were talking about. Anything that can interfere with ventilation, that's going to be a mechanics of breathing issue. For instance, if your patient has a gunshot wound, a large hole in the side of his chest, that's going to interfere. That's a mechanical issue there. It's going to interfere with respiration. You could have a gas exchange problem where the gases are not being able to be exchanged. Can you think of an example where the gas exchange might be at issue? Okay, fire guys, this is for you. Yes, that's a possibility. Wasn't where I was going, but yes.
Bronchial constriction?
That's part of the mechanics, I think. Don't I have more than one fire guy in here? Come on, fire guys. What about confined spaces that can interfere with? Yep. So it's the gas issue. If you have a low oxygen level, if you've got a high carbon monoxide level, that's going to interfere with gas exchange. Cyanide, that's going to interfere with gas exchange. So that can interfere, that can cause a gas exchange issue. So yeah, if you're breathing in air but it has low oxygen in it, then you're not going to get gas exchange. How about circulatory problems?
Not enough blood.
Yeah, if you don't have enough blood, you can't circulate oxygen and pick up waste products. What else? Trying to think if I have one more on here. Let me go back. Nope. What else can interfere with circulation if you think of it in those terms?
Hemoglobin.
Do what?
Hemoglobin.
Yeah, if you don't have enough hemoglobin, you're just circulating red blood cells but no hemoglobin, that's probably going to interfere more with the gas exchange. What else in circulation can interfere with circulation? Movement of blood. What makes blood move around? Yeah, if the heart's not working, the pump's not working, if the electrical system's not working, all those are going to interfere with circulation. So there are a lot of different things that can have a negative impact on our respiratory status. So if you have a patient with respiratory issues, they're not breathing enough, they're not getting enough oxygen, you've got a lot of different areas to look at instead of just one. If you have, say, an asthmatic and he's wheezing a lot and he's starting to get cyanotic, what are the areas here physically that could be causing his respiratory problems? Y'all said most of them already. Bronchial constriction, absolutely. What else? That's a biggie. I mentioned the other day, I probably don't remember, with asthmatics, they build up mucus in their lungs also, and that mucus interferes with that gas exchange. Remember I kind of showed you the alveoli, if you've got a layer of mucus around it, that oxygen and carbon dioxide really have to jump that gap in order for gas exchange to occur. So based on what's wrong with the patient, you're going to be having to look for what's interfering and what can you fix and what can't you fix. And respiration. We know that our cells need oxygen, and they need more than just receiving oxygen. They have to be able to gas that stuff off. They have to get rid of the waste products that also come with that. Hypoxia, the term hypoxia means low oxygen level in the cells. So hypoxia just means the cells aren't getting enough oxygen. Carbon monoxide has to be removed constantly as a waste product. Hypercapnia, that term hypercapnia, hyper means what? A lot. Yeah. So hypercapnia means we have a lot of carbon dioxide that's built up in the cells in the vascular system. When we have a lot of circulating carbon dioxide in the vascular system, are we going to be acidotic or are we going to be acidotic? Basic. We're going to be acidotic. So that's how do we get rid of high carbon dioxide levels? How do we get rid of that mostly?
Take a breath.
Yeah, we breathe it out. Most of the time that carbon dioxide, which is a waste product, is going to be excreted through through the respirations. So when we're evaluating a patient, we want to determine what their oxygenation status is or what their respiratory status is. And we will recognize that by how well they are being oxygenated and how well they're getting rid of waste products. So your patient is going to show different signs and symptoms based on their acid or base level. You know, if they're too acidotic, they're going to show one set of symptoms. If it's the opposite, you're going to see something different. So we're going to start to look at what these signs and symptoms are. And I want you to understand where they come from. Okay, you have a patient that's real short of breath. She's real short of breath. It could mean probably means she's not getting enough oxygen into her body. So that's going to be a sign that there's a respiratory problem. You know what? I should have talked about this title. Compensation. We talked about compensation, I know, a couple of weeks ago. So if your patient's not getting enough oxygen, the body's going to say, hey, we got to do something. We got to get some more oxygen in here. So it's going to start compensating. So how does it compensate? One of the first things you're going to see is they become short of breath, but not become short of breath, but they start breathing faster, right? They show signs of shortness of breath, and to fix that, they'll start breathing faster. They'll increase their respiratory rate and their depth. So they breathe faster and deeper. Other things you'll notice, and we talked about this, increased heart rate. Now, early on, when the patient's just starting to have some issues, the body compensates okay. But if it's not able to catch up, then it's going to get worse and worse and worse, and it can't catch up. So early on, we're going to say they're compensating well. After a little while, they're not going to be able to compensate, and they'll decompensate. It's kind of like if you went out there, and this is going to be different for everybody. If you went out there and ran a half a mile, your heart rate's going to increase. You're going to be, breathing a little bit heavier, a little bit faster, maybe not a little bit deeper. But if you had to go out there and run a marathon, for you guys that might run a half a mile on a given day, by the end of that thing, you're not going to be in compensation. You're going to be decompensated. You're going to be almost dead because the body can't keep up. And that's going to vary based on the status of your patient. If they're really sick, then the slightest little bit of compromise is going to be very detrimental to them. But if you're really healthy, you can compensate or you can handle that a whole lot better. Honestly, most of the patients we see are not in very good condition, so they struggle more than your well person. Okay, this young lady is in respiratory distress. Now, distress is going to be our least critical level of respiratory issue. She's in respiratory distress. She's compensating. How is she compensating for this? The way she's sitting. By sitting up and leaning forward like that, she's taking pressure off of her chest. She can breathe better leaning forward. Of course, we've given her some oxygen, so that helps her. So respiratory distress. These are going to be patients that they are compensating. They're having some issues, but they're taking care of them. They're managing it. So respiratory distress, they have a relatively normal mental status. And this is going to be one of your keys to recognizing somebody that just has respiratory distress. You know, if I looked out here and one of you guys is breathing, 22 times a minute while everybody else is breathing, 14 or 10, some of you 8 times a minute, they may keep a normal mental status because their body's keeping up. They're having to breathe a little bit harder, work a little bit harder, but, hey, it's all working. They should have a relatively normal oxygen saturation. Remember last night in vital signs, y'all used the pulse oximeter? Check the pulse oximetry, and it gave you a percentage on there. Yeah, 95 and above is considered normal. So they'll stay in that relatively normal stage, range. They'll keep a relatively normal skin color. They're not going to look like bright pink, but they don't look like death warmed over either. So, they look okay. You'll notice they're a little bit short of breath, but they're still able to talk to you, but they have a little bit of shortness of breath. All these are respiratory distress. Increased respiratory rate, increased heart rate. They're just in distress. They can remain in distress for some, reasonable amount of time. I mean, hours, it could be days they could keep up like this, keeping a normal mental status. Respiratory distress. You may start to see them use accessory muscles. Once you start seeing, them using muscles in their neck, muscles in their chest, once they really work with the whole position thing where they're sitting forward, head tipped up, nose up, maybe nasal flaring, now they're starting to move away from distress. They're starting to get worse. So the key here is going to be relatively normal mental status. They have an issue, but they're not fixing to die. That's always good. The next one is respiratory failure. Now, respiratory failure means their compensatory mechanisms or their compensation is not working. It's failing them. The bottom one is respiratory arrest, where you're not breathing at all. So we really have 3 layers. Respiratory distress, if we get in there and manage it, patient usually has a good outcome. Respiratory failure, we're moving pretty quickly because they're not doing well. So with respiratory failure, this is when the challenge of compensating can no longer be met. So they're doing everything they can, but they're still sliding backwards. As long as they're holding their own, everything's good. But once they start sliding backwards, they start getting worse. Now we're looking at respiratory failure. Also known as inadequate breathing. And we're going to talk a lot about adequate versus inadequate breathing, because that's going to be the key for you to recognize patients that you need to step in and take some positive steps to assist them versus not. So it's a concept that you're really going to have to get a grip on. It's especially important to recognize because if you've got a patient with respiratory failure, the next step for them is respiratory arrest. And this is a slippery slope. As long as they're compensating, they're going along like this, but once they start in failure, they're going straight down unless you have a very quick intervention in here and stop it. But you need to catch them when they're still at respiratory distress. Signs of failure. Top of the list, altered mental status. Now, when we talk about altered mental status, sometimes students will think altered mental status must mean they're somewhere along the line of being, alert and oriented to being not alert to being unconscious, and that's not the case. Most of the time, your patient will go from being alert and oriented, and then when they're not getting enough oxygen, they become tachycardic and their respiratory rate increases. They start getting anxious and start getting a little weird, and they're getting really nervous and they're real jumpy, or they may become combative or angry or cross. That really isn't a form of altered mental status. Not the kind you get, when you get mad at something and you start cussing, causing you to be cross and angry. This is when your brain's not getting enough oxygen and it starts to get stressed and your patient may behave badly. That is an altered mental status. If you came in to treat me and you can tell I'm fidgety and I'm like this, and I'm real cross and I'm anxious, and you notice that my skin is really pale and I'm breathing 28 times a minute, kind of shallow-like, that's going to be a sign of an altered mental status. So those are the types of things that you're going to be looking for to recognize that your patient may be hypoxic. They're not getting enough oxygen in. And that also is a range too. At the beginning, they're anxious. They may be combative. But by the time they're sliding from failure to arrest, then they may be completely confused, completely disoriented before they pass out and they're totally unconscious. And you could have respiratory failure in a patient that is unconscious, but they're still breathing. These patients are going to show signs of respiratory distress, but you'll recognize that their compensation's not working for them anymore. You'll notice that their pulse oximeter reading is dropping. It would not be unusual to have somebody in 90, 88 percentile with this. But you'll see other signs. I talk about skin signs a lot. What would be the skin signs that you would probably notice if somebody didn't have enough oxygen?
Cyanosis.
They might be cyanotic, meaning they're kind of blue around the gills. What else would you notice? They may be diaphoretic. We've talked about that word diaphoresis. That means you're sweaty, but you're not hot necessarily. They may be diaphoretic. You see that? Well, what else might you notice? Skin signs. You what? You could do a capillary refill. Is that what you're talking about? Yeah, you can do a capillary refill, which means you press on the finger and the color should return within about 2 seconds. It's not real accurate with older people, but with your 5 years and younger, it's usually very accurate. You might notice they start getting real pale looking. Why does that happen? Why does somebody in respiratory failure or even respiratory distress, why do they get pale?
They're not getting enough oxygen. You know, the blood flows.
Yeah. All right, let me put it another way. If you touch their skin, they're going to feel really cool. Why do they feel cool? Okay, your body's freaking out. It's all distressed because there's not enough oxygen to go around. Okay, all right, it's your family of 4, and you've got all those other people that live in your neighborhood. And you only have just enough for your little family. What are you going to do? Going to tell the rest of the neighborhood, I'm sorry, I got to feed these guys first. Well, same thing with your body. Your body says, well, I only have enough to go around for part of you, and I'm going to keep the important parts, the brain, the heart, the kidneys, a few special things like that. What's going to be the first organ system to go? The skin, gastrointestinal. Yeah, some of those not quite so important according to the brain. We're going to roll those to the curb. We're going to say, you're not getting oxygen, not getting blood flow to you, so you're going to vasoconstrict. I mean, if you're going to lose something, would you rather lose a fingernail or a toe or some brain cells or heart cells? Y'all don't care? Nobody here cares? I'm keeping my brain cells. I don't have enough to go around right now. So your body does that. It's a system of, okay, you're more important than you are, so it's going to feed the important organs and let the others go. So vasoconstriction occurs. That the extremities are going to get cold, they're going to get pale, and they may be diaphoretic as a result for different reasons. So those are going to be signs that you'll notice that your patient is poorly, what's the P word? Perfused. Exactly. They're poorly perfused. And perfusion really is going to be the delivery of oxygenated blood to the tissues and the removal of waste products, right? So if all of those are vasoconstricted, so we're not sending any blood there, they're going to show signs of poor perfusion, that we're not getting good blood to the whole body. You'll see signs of decompensation, that they're not compensating anymore. Signs of failed oxygenation, altered mental status. That's the number one thing you're going to notice. These are patients that are confused. They can't remember what you're telling them. Early on, they may be combative and difficult. After a while, they may become obtunded. You remember that word? They're obtunded. They they're so confused, they can't stay awake, they start losing muscle tone, and then they go into unconsciousness. Decompensation, they're either breathing so fast that they're not able to get air in, and that's going to be early in the process. After a while, they don't have the energy to move the chest in and out. So their respiratory rate is actually going to drop off, decrease, 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 because it takes a lot of energy. If you try to go, if you do that for a little while, it'll wear you slap out. It's kind of like doing CPR. Y'all done some CPR? If you've done it for real life, after you've done it for a couple of minutes, it's like, this is work. So it'll wear you out. So trying to breathe will wear out your patients, especially the ones that don't have very good health anyway. If you auscultate, you'll notice they're not filling their lungs well. You won't hear that swishing of air through there. So you'll notice diminished breath sounds or absent breath sounds. Respiratory rate first is too fast, and then it's too slow. Then it may become irregular. Any idea what we call that very slow, irregular breathing? Like 3 or 4 times a minute? Come on, give it to me. It's in your book. Huh? No, bradycardia is slow pulse. Y'all can look at that. What do you call it when the respiratory rate is very slow and irregular? It starts with a vowel. It starts with an A, and it's not apnea. That's a good guess. Y'all killing me. I'm going to write notes so they'll come out. Y'all get close. Agonal, yeah. Agonal. Sounds like agony, doesn't it? Yeah. Your patient goes into agonal breathing, and then they don't breathe anymore. They're just like dead. You'll notice they're in severe respiratory failure if they can't talk while they're trying to breathe. You're going, they can't talk. They might get 1 or 2 words in at a time before they have to stop and take a breath. I mean, if they're really huffing and puffing, they can't talk to you. Or their respiratory rate is so slow because they are not getting enough oxygen in. They go into anaerobic metabolism. Remember how much energy is produced in anaerobic metabolism? 2 moles. That's right. So we're not getting enough energy for them to even expand their chest anymore. They are what? FTD? FTD? Anybody? Fixing to die. Yeah. You may also hear unusual sounds in that wheezing. You may hear some stridor, snoring, gurgling, gasping. With pediatric patients, one thing I do want you to know with little kids, respiratory is the most common cause of cardiac arrest for them. They don't just go into cardiac arrest because they've got heart disease. It's because they've had a respiratory problem. So if you can manage a child's respiratory issues, then you may be able to fix them. So with addition to all the signs that you see with adults, you also see retractions more with children and nasal flaring. You know, like they just like flare out their little nostrils. You've seen them do it, little kids. They're breathing, they just don't see that so much with older people. When to intervene? This is always a difficult question for students. At which point do you jump in there and do something? And I know y'all have been checking off on your airway stuff. You know, we use a non-rebreather. What kind of person, what kind of patient or patient condition or situation would you use a non-rebreather?
The person is breathing adequately.
Yes, they have to be breathing adequately. If your patient's only breathing 6 times a minute and we put them on oxygen, now what have we got? 6 breaths a minute with lots of oxygen. It's still only 6 breaths a minute. If you're breathing 50 times a minute, you're going, and you've got a non-rebreather on them, are you getting oxygen down to the alveoli? No way. So those patients are breathing inadequately. So, I mean, you could just, it's kind of like sometimes I say if I could, I probably shouldn't tell that, but it's just like smearing oxygen all over their body. It's not getting in there because they're not breathing adequately. So you have to determine that they're breathing adequately if you're going to give them a non-rebreather. So if they're breathing 6 times a minute and it's really shallow, how are you going to get oxygen to them? You know what? Yeah, got to bag them. You're going to have to ventilate them. You're going to have to put that oxygen in there. Okay, so when are you going to intervene? Sometimes you're going to have patients that are in respiratory failure, means that they're moving towards respiratory arrest, but they're still conscious. They're looking at you. Now, they may not have a good mental status. They have an altered mental status, but they're looking at you, and they're thinking, I'm fixing to die. I hope you're going to help me. And then you come at them, you know, like, da-na-na-na-na-na-na, with your bag valve mask. It's very difficult to put a bag valve mask on a patient that's awake and looking at you. But sometimes you may have to do that. And if they've ever been bagged before when they were conscious, then they will appreciate that. But if they've never had it before, it's scary. All of a sudden you put a mask on their face. I can't breathe, and you're putting a mask on my face? Real scary.
Does that altered mental status qualify for where they can, like, it's just implied consent?
There's going to be a point there where it would be implied consent. You know, you can be anxious and freaked out, but you still know what's going on. But as they move into that decompensation area, fixing to go unconscious, they may not meet the legal definition of being alert and oriented. So that's a good question. Wait a minute or two and they'll be unconscious. And then it's the truth. Okay, if breathing is inadequate, you have to breathe for them. If they can't sustain life by the way they're breathing, you've got to do it for them. And I'd rather err on the side of trying to do it for them, and they, you know, knock you out of the way or say, I can do this myself. So, okay. But I don't want to sit there with somebody in a non-rebreather and they're breathing 6 times a minute and they're turning blue all over. You know? It's just not going to happen for them. You're going to have to intervene. What signs might identify the need to intervene in a breathing patient? What are the things that you're going to notice? What's the number one thing you're going to notice?
Chest ache.
Before that. For respiratory, remember it's been at the top of all my list? Mental status. We already know they have respiratory issues, but to determine, you know, when it's really getting bad, you're going to watch mental status. If the brain's not getting oxygen, it's going to make somebody pay for it. Any signs of respiratory failure? Any altered mental status? Slow, irregular respirations? Cyanosis? I went through that pretty quick. All these would indicate to you that you may need to bag a conscious patient. Positive pressure ventilation. This is when you're actually going to be forcing the air into the patient's lungs. Yeah, I just said that. So you may do this if they're breathing inadequately or if they're not breathing at all. So you will determine if your patient's breathing okay, well enough to sustain life, well enough not to get any worse, then you can put them on a non-rebreather. But if that's not the case, you're going to have to bag them. There are 2 things that you're going to have to look for specifically when you're determining if they're breathing adequately. Now your book may not say this exactly, but everything boils down to rate and volume. I was working with the paramedic students the other day, and I'm going, don't they understand? Even my EMT class understands about rate and volume. So when y'all leave here, you got to understand about rate and volume because they weren't getting it. They weren't my students before this. Rate and volume. If you're not breathing fast enough, if you're only breathing 6 times a minute, it doesn't matter what your volume is. You're not getting enough, right? For example, we should be breathing, just average, in the course of a minute, we should be breathing in about 6,000 cc's, okay? What was I telling you a little while ago? Average, we have 150 in dead space, right? Usually we breathe between 500 and 600 cc's per breath. So if you're breathing 6 times a minute, kind of slow, and you are taking in 300 cc's each time, how much of this is reaching the alveoli? Half? Yeah, so just think about that. But our minute volume would be 6 times 300, right? 6 is the number of breaths, and this is the volume. So this really is rate and volume, right? Rate and volume, so how much is that? Oh, that doesn't even look like an 8, does it? Anyway, so how does this compare to this, if this is normal? Is that good or bad? Bad. That's real bad. So, on the other side of that, oh, I love this. Oh. Say you have somebody that's breathing, what's a good round number? 50 times a minute. And that's a lot. And they're taking in 100 cc's each time. Y'all want to try that? Pretty fast. So what's his minute volume?
0.
Well, how much he's really moving, not alveolar volume, but his minute volume.
Less than half a minute.
Yeah, well subtract out. Don't do 150. Yeah, it's gonna be 5,000. But we said normal was 6,000, right? Isn't this 5,000 close enough? Yeah, this 5,000 is not enough when you figure that they're doing 50 times a minute, because all they're doing is moving air in and out of the dead space, right? Even though it's 5,000 cc's, it's not reaching the alveoli, so it's not doing any good. So rate and volume is going to tell you if your patient's breathing adequately or not. If they're breathing 20 times a minute and they're taking in 600 cc's each time, what's that math? All right, I'm going to help you here a little bit. Breathing 20 times a minute, 600, 12,000. That's a lot, isn't it? That's a big breath for somebody breathing 20 times a minute. They're going, do what? My math wrong?
12,000.
Oh, yeah, you're right. Yeah, if you're breathing like 12,000 when it should be half of that, right? You're going, try that for a little while. I'll tell you. So, if you're breathing 20 times a minute and you're taking in 600 each time, are you breathing adequately? Not really. You're breathing way too fast. You're not releasing much carbon dioxide. That patient's not doing well. We'll talk about those patients and what that really means at some point too, later on. Okay, when we're doing positive pressure ventilation, and this is another physics thing, we're doing positive pressure ventilation. Your patient is not using that negative pressure in their chest anymore. It's of no value to the patient, that negative pressure. Positive pressure means we are providing positive pressure into the lungs. So it's not a normal process. Think about what happens when you have that negative pressure in the chest expands, air comes in. Part of that is going to help actually the heart to compress. As we breathe in and out, it's going to apply pressure to the heart and kind of help it move blood through too. When we're doing positive pressure ventilation, we don't get that positive effect on the heart. All we're doing is moving air in and out. So it's not as good as your patient breathing for themselves. Negative side effects of positive pressure ventilation. That's kind of what I was getting at. When you are having to force air into the patient's lung, it decreases cardiac output. Just like I was saying, that negative pressure in the chest when we're breathing helps assist the heart to move blood out of it. With positive pressure ventilation, we don't get that effect. It actually decreases that blood flow. For example, well, it's not a real close example, but when we're doing CPR, they're moving away. In the olden days, we used to give them one breath after every 5 compressions. 1, 2, 3, 4, 5, breathe. And it was 1, 2, like this. We gave them about 60 to 80 compressions a minute. Then we gave them a breath because we felt like, you know, the body has to remain oxygenated. Well, as you know, when we exhale, we're exhaling what? 16%. So there's really a lot of oxygen still in there. But the big deal was to circulate that blood. Well, when you're doing CPR, of course, you're compressing the heart. but you're also passively bringing oxygen into the lungs. So we're really, that pressure in there is very useful for us. But with positive pressure, when we're blowing air in there, it decreases cardiac output. Also, when you're doing positive pressure, bagging your patient, it's really easy to get air into the stomach. So think about that stomach. Every time you put 10 cc's of air in there with each compression, you put just a little bit in there. Over the course of 20 breaths, how much air have you put in the stomach? It's another math problem. 20 breaths in a minute, and I put 10 cc's in every breath.
200.
I put 200 cc's in the stomach. That's a lot. Most stomachs aren't that big, but you probably put in at least half of this in there. 20 cc's, probably about that much. But yeah, you continue that for several minutes, and what's happening to the stomach? Just like a balloon. And then what's the patient going to do?
Throw up.
Yeah, they're going to throw up. But even then, the stomach is getting so large that the heart can't expand and contract. The lungs can't inhale and exhale normally. So gastric distension is always bad. How do you think we end up putting all that air in the stomach anyway? Two main reasons.
Too much oxygen.
Yep, you're forcing air through there too quickly. The trachea is only so big, and if you're trying to squeeze a lot quickly, that air, only so much can go down that tube. Where's the rest of it going? In that big tube, the esophagus, which is quite large, and into the stomach. Another thing that causes gastric distension is if you don't have the airway open. Like if you haven't put the head back all the way, it's only partially there, then you're not going to get a good clear access to the trachea. You'll get some clear access to the esophagus though. If you hyperventilate, and that's something that we do, we all do it, everybody hyperventilates. A few years ago I was doing a lecture to some paramedics down in Florida, and we did an experiment. The very beginning I had a couple volunteers come up and do CPR and ventilate the patient. And actually, no, we weren't doing CPR then, we were just ventilating. And they were supposed to ventilate, what's our normal respiratory rate? Yeah, as we breathe, about 12 to 20 is our normal respiratory rate. When we're bagging them, we're going to bag them usually 10 to 12. So when a patient's intubated, we drop that back quite a bit. We might do it 6 to 8 times a minute. So these paramedics should have been ventilating about every 6 to 7 seconds. And so we counted them over the course of a minute. Each group ventilated the patient between 40 and 45 times per minute. Of course, you know, they're in front of a whole crowd of people and everybody's watching. So you know what I'm saying? They're going 1, 2, 3, 4, really, really, really fast. So then I presented my lecture about how bad it is to overventilate or to hyperventilate, how it prevents the heart from expanding, contracting, and all that kind of stuff. It took about 30 minutes. And then we got 2 more people up and we did the same thing again. Exact same thing again. They had just heard what I told them about overventilating. They got the nasty lecture about doing it. So they did it too, again, and now they've ventilated between an average of 24 times a minute. Still twice as fast as it should have been. So even when you know better, even I just sat there and told them how fast to do it, and they still overventilated. So we all do it. So you have to make a conscious effort not to overventilate, not to hyperventilate your patient. It's so important. Pretty
For a
soon,
child, it's like 3, right?
depends on what their age is.
Small.
Infants, they'll be once every 3 seconds, pretty
So
much.
5 and
1001, 1002, 1003, breathe. For the adults, you're getting to 6 seconds. Okay, key concerns with PPV stands for positive pressure ventilation. If your patient's vomiting, we don't want to force a bunch of oxygen in there and force vomit down into the lungs. It's always bad. We call that aspiration. So we don't want them to aspirate. It's never good. When you're ventilating your patient, how much air do you want to put in to their lungs? At which point do you know you've done enough?
For the chest
6.
rise.
When the chest rises. As soon as you see it move, you're done. Make sure your rate is sufficient. That means 6 times a minute, not, every 6 seconds, or 8 to 10 times a minute in there. Don't do too fast and don't do it too slow. Nobody does it too slow. It's not even an option. If your patient's breathing and you have to ventilate them, you need to explain to them exactly what you're doing, because it's going to freak them out. They're sitting up there, because why are they going to be sitting up? Yeah, if they have enough consciousness level, they're going to be sitting up, because they don't want to lay down because they can't breathe. So as long as they can hold themselves up, they're going to be sitting up. Once that patient in respiratory distress lays down, you know they're fixing to die. They're fixing to stop breathing. So they're laying down in respiratory distress. You've got somebody circling the drain there. So they'll probably be sitting up. You may prop them up in Fowler's position, and you'll just place tell them what you're doing, put that mask over their face, and start bagging them. Just say, work with me here. Take a breath when I push this bag in. And then you set the tone for them. You set the rate. It's difficult. Mouth to mask ventilation. According to American Heart, this is the best way to ventilate a patient. Can you think of why that would be the case? What would be useful about using a mask that's better than using a bag valve mask for your patient? Well, so you can do a better job. What is it about?
It's harder for you to overventilate someone?
It is harder for you to overventilate, because you can't flatten your lungs. It's not going to happen. You're going to keep air in there. So yeah, you can't give them more air than you already have. So the chances of overinflating them is significantly reduced. That's a good one.
Your oxygen concentrate is higher?
My oxygen concentration won't be higher than if I was using a bag valve mask with oxygen tank. You actually are giving them less oxygen because you're using some of that. We're only exhaling 16%, right? You think of anything else?
You're not going to ventilate too fast, because then you would be.
Yep. You can't ventilate them 44 times a minute. You will die first. Yeah. It's easier to keep the rate. It's easier to keep the volume. And you also can tell when the lungs are non-compliant. And I know we've talked about that term. It's difficult to understand. Meaning you're trying to blow in and it won't go. If you're blowing in and it won't go, you can feel that. And that's going to tell you things like, oh, I must not have the airway open. I need to tip the head back. Or if you're blowing on there and it's really not going in very well, there could be some other kind of blockage. Or they could have a tension pneumothorax, which we'll talk about later in the semester. So it lets you know that there's a problem. But if you're doing a bag valve mask like this and you've got a little air leak over here, you may not even notice it. If it's starting to get hard to push, you may just push harder. But you're not going to do that when you're ventilating a bag. So you should have one of these and you carry it with you in your car, if you come up on a wreck or something like that. But you won't be using these on the ambulance anywhere.
And that helps too, like if you're just by yourself also.
Oh, yeah.
Better than doing the bag by yourself.
Yes. Oh, absolutely. This is going to be much better because you'll hold it on their face and blow into it. So yeah, you get much better control, whereas the bag valve mask by yourself is it's never a good idea, but sometimes you can help it. Performing mouth to mask. Did you guys do that with Tim? You got the pocket mask out? Remind me to do that. You're supposed to do that in CPR. Did y'all do it in CPR?
Yeah.
Okay, so you've all done that. When you're doing that, you need to hook it up to oxygen, flow it at 15 liters. I said all that. As you blow into it, then you need to back up. You take a breath, and during that time, the patient exhales. It doesn't come out on you anywhere, but it has a little valve there that allows it to exhale. Make sure you get a good mask seal. This is whether you're doing a pocket mask or if you're using the bag valve mask. It's important that you get a good face seal, because even a small little pocket where air is blowing out the side, you're not going to inflate the lungs. Bag valve mask. You can see these are 3 sizes. We're required to carry 3 sizes: an adult size, a child size, and an infant size. And the masks are different sizes. The bags are different sizes. But there's a little connector in here where you can interchange these different masks. So if you had a patient, an adult patient, say, and had a stoma, and you needed to ventilate that, which one of these masks would fit better, this big adult one or one of these little baby ones? Sure, either the child or the infant size would fit better, And which bag would you use? For your adult patient?
Big
Yeah,
bag.
the big bag. Just put the little mask on the big bag and you'll be good to go. Handheld ventilation device were used to ventilate non-breathing patient or a patient in respiratory failure. Standard features, that bag will refill itself. You don't have to do it. I did tell you that they're disposable. You use it on one patient and then you ditch them. It's got a little oxygen inlet so you can connect that up. It's got a non-rebreathing valve, which means it doesn't come back into the bag or anywhere. It goes out to the side. There we go. Anything else? I did mention to you about the reservoir. There's a couple of different types of reservoir. You must have a reservoir on your bag. Without that, your oxygen concentration is somewhere like 50% or something. You get a bag on there, and it doesn't have to be full. You know, in the non-rebreather, when you backfill it, that's got to be full. This doesn't have to be full. It's got to be there, though. Okay. You're going to have to read that. Okay. Anytime you're using a BVM, you should use two people. What do the two people do? One does what? Not for CPR, just for using the bag valve mask.
Holds the mask,
One's going to hold the mask in place and
the other one's gonna push it.
before
Open
the
airway.
and keep the airway open,
Yeah.
and the other one is going to squeeze the bag. Yeah. So even if it's not a member of your crew, you can get a family member on scene or a bystander or somebody. You can get them to squeeze that bag for you while you hold the mask in place. That's okay. The hardest part is going to be getting that mask sealed. That's why I prefer you to do that and have your bystander compress the bag. Okay. So if your patient doesn't have a traumatic injury, you don't suspect a spinal injury, you're going to do the head tilt chin lift, right? Now, is this, yeah. We already did that. Okay. How are we doing so far? Pretty good. If you suspect they have a traumatic injury, then you're going to do the jaw thrust. This is going to be much more challenging for you. With these, you really do have to have two people. One to keep the jaw thrust in place and hold the mask, and then somebody else to squeeze the bag. This is
Now,
always a...
Ms. Curry, when you have a trauma like that and you do the jaw thrust,
Mhm.
you're not supposed to tilt the head back when you do the jaw thrust.
You're not supposed to
If
tilt the
you
head
think
back.
they have a spinal injury.
Right.
But if you don't think they do, then you could tilt it back.
Yes. And you would look at mechanism of injury, and I think that we haven't talked about that yet. We're going to talk about it next week. Mechanism of injury, if they fell, 5 stories, then you're going to suspect they have a spinal injury, right? If they twisted their ankle like I do up here on these stupid things all the time and I fell down, you wouldn't expect a spinal injury because I haven't had a significant fall. So you're going to base that on what caused the fall, the mechanism of injury. That's a good question. However, if you had a patient that wasn't breathing, a traumatic injury, you did everything that you could and you couldn't get the airway open, you couldn't get them ventilated, for whatever reason you couldn't do the jaw thrust, it's going to be life over limb. So in that event, you may have to tilt the head back just enough, a little bit, till you can get an airway. But that would not be your first, second, or third choice. You would only do that if you can't secure airway any other way. Then you may tip that head back enough to get an airway. One rescuer BVM, very difficult to do. The best way to manage this usually is going to be if you will put the patient's head between your knees so you can control their head, hold the mask, and try to squeeze like this. Doesn't work very well. If you are trying to ventilate your patient and the chest doesn't rise, that means you don't have a clear airway. You're trying to get air in, that's not the problem. The problem is the airway's not patent. So you're going to have to re-tip the head. That's always the first thing you're going to do is try to re-tip the head. If it's a trauma patient, you've done the jaw thrust, you're not getting air, try it again. Maybe you didn't open it far enough. You didn't pull the jaw forward enough. So try it again. Reposition the head. Next, look at the mask. Is there air leaking out from around the side? You need to reposition your hands so that you've got better control of that. Look to see if there's some other kind of airway obstruction. If you're not getting any air in, is there a problem with the mouth? Do they have a blocked airway where you may have to do choking maneuvers? Is there
Do you use the suction at that time too to just see
You could try that, see if you get something. Usually you're going to see that and know that it's a problem in advance of that. Usually, well, usually. Okay, if you have a patient with a stoma. Now if you look at this guy, if you imagine he was laying down, you can see how the airway goes like this. And this is the trachea up top. So you have this little curve thing going, right? So that's one of the problems. That's why we tip the head back so we get a straighter line down the trachea. Now this guy is not breathing from his mouth and nose. He's breathing from the front of his neck. Now try to imagine, if you tip his head back, is that going to help you get air in there? No, it doesn't change that angle at all. That's not a problem. So with a patient who has a stoma, you don't have to worry about tipping his head back. He's already got his best body position. So that's the kind of thing you're going to see on registry. You're not going to tip that head back. But people that are have stomas, they usually have long existing respiratory disease. And that's why they have this. Because of having to breathe here, the other things that occur is they build up a lot of mucus. The cilia that help move that thick stuff up and out, it doesn't bring it up and out here. Like, you know some people that are always clearing and doing this kind of stuff, particularly when you get older. But we move it up and out, or up and swallow. You know, we move it up and it goes down the esophagus. These guys don't have that option. They don't get it up this far. They can't get it to swallow it or get it out. So it builds up in here. So very frequently you're going to have to suction them. It's very common that you have to suction them because they can't clear their own airway here. Yes?
Did you just plug it?
We'll talk about that.
Is the stoma the same thing as a trach?
It's a hole in the front, yeah. Now, some patients may have it where it's just an empty hole like that. Others may have a device, a little piece of plastic that actually goes in here. Yeah, it's basically the same thing.
So when it's plastic, is that when it's called trach?
Yeah. So if they have a little plastic piece, you're just going to suction right through there. Sometimes it's just a naked hole right there. It looks kind of weird. What were you asking me?
I just said if you can't get the chest to rise and you're doing it through the stoma, can you just plug it and try to
Yeah,
make it so
that's a really good question. Now, some people may have a temporary stoma here. Where have you known somebody with that? Is that where you're saying that? Or
Well, my grandma had it,
uh-huh.
and she had some issues before she died, and I think they plugged it up and had to do through her mouth
Yeah.
to get her to ventilate, because it was something, it was like her trachea had become part of it, you know, where it's,
Oh, it grown into it.
and so it was not something going on.
Sometimes you'll have patients that this is a temporary stoma. For instance, if you had a patient, say you're a paramedic, you had a patient that was choking, you couldn't get any air through, they did emergency crike where they cut a little hole, put a tube in through here. That would be temporary, and the patient would still have access to the mouth and nose. Patients that have been very ill, where they've had, you know, cancer, where part of this has been removed through the mouth, this sort of thing, theirs may be completely blocked, and there is no access to the mouth and nose. So say you were trying to ventilate through the stoma, and you know, you've got your little baby mask, and you've given it this number, you're not getting any chest rise. Now, if this was a regular patient that you were bagging, and you're trying to do this, you're not getting chest rise, what's the first thing you're going to do? Reposition the head. Remember, we talked about that just a minute ago. Now, in this case, if you're not getting any chest rise, are you going to reposition the head? No, because it's not going to make any difference. But you may suspect that they've got either a blockage in that they've got mucus or something. How would you tell the difference between if they had mucus blocking it, or this was a temporary stoma and this airway was open? How would you tell the difference? All right, I'm bagging like this. If they've got, if this is complete, no access up here, and I'm bagging and it won't go in, what could it be? Yeah, they got crap in there, blocking it. You're going to have to suction that out. Say you were bagging it like this, and you don't see any chest rise, but there's You feel that air. I'm just pumping it away. It's going somewhere.
You got leaks.
You know, not holding it good, but it's incomplete and it's coming out up here. So in that case, what are you going to do? It's almost like Cindy described.
Plug it.
Yep, you're going to plug something. You're either going to plug this and bag them here, or you're somehow going to close this off and bag here. Probably going to bag here. If this is incomplete, I'm going to bag this here and just cover that up. So based on the response that you get, if you're trying to bag and it's really, really hard, you're not getting any chest rise, that air's not going anywhere, what is it? Y'all killing me. It's going to be blocked.
Can you push the cricoid too to help open the, like, somebody said that one time in that CPR class, that if you push this, your Adam's apple, it opens it up or something, or?
Well, no. When you apply cricoid pressure, Selleck's maneuver, when you're pressing there, since you have cartilage on the front of your trachea, it doesn't impact your trachea at all. As you press it down, it may block the esophagus, but that's not going to help you with ventilating anybody. The main reason they do that now is just when the paramedic is intubating, if they can put pressure here, it lowers the cord so you get a better view, really. That's the only reason they do that anymore. That's a good question. So nobody's going to tip the head back on this stoma breather, right? And if you're trying to ventilate and it's really hard and you can't get any air in, what are you going to do? Suction, right? And if you're ventilating, chest doesn't rise, but air's going everywhere else, what are you going to do? Yeah, you probably got it incomplete here, and you'll close off the stoma and bag through the mouth and the nose. Or make sure that you're not losing all that air around the mask. Okay. We're doing all right. Y'all want to take a short break? Oh, yeah. Yeah, y'all run out for about 5 or 10 minutes. Let me turn this thing off.